All right, let's get right into it. For anyone working in medical microbiology here in the Netherlands, 2024 is a huge deal. It marks a really fundamental turning point in how we deal with rotavirus. A major public health decision has literally just changed the game, and in this explainer, we're going to break down exactly what that means for the virus, for our patients, and most importantly, for you in the lab.
First, let's start with just a number, 3,500. Now, this isn't some abstract statistic. This was the reality, year in and year out. Around 3,500 kids hospitalized in the Netherlands. Every single year, all because of rotavirus. That's the heavy burden that has finally pushed this change forward.
And here it is, the big one, the landmark decision. As of January 1st, 2024, the rotavirus vaccine is officially part of the RVP. This single policy shift takes our entire national strategy from the hospital bedside to the public health clinic. And that has some pretty profound implications for how we track and really understand this pathogen from now on.
So that's where we'll start, this 24-24 paradigm shift. We're talking about a move away from just reacting to infections as they happen and towards a strategy of proactive, large-scale prevention.
And the reasons for this, well, they're crystal clear. First, it's about preventing those thousands of hospital stays we just talked about. But it's also about averting the absolute tragedy of 5 to 6 pediatric deaths every year. So the key takeaway here is that this is a deliberate, strategic pivot. We're moving from just managing sick kids one by one to preventing the disease across the whole population. Okay, so to really grasp what this new surveillance landscape looks like, we've got to refamiliarize ourselves with the enemy, right? Think of this as a quick virological refresher, but specifically for this new post-vaccine world. Knowing the pathogen's blueprint is now more critical than ever.
So, what is rotavirus at its core? Well, it's a member of the Reoviridae family. The key things to remember are, it's non-enveloped, which makes it incredibly tough, and it has a segmented, double-stranded RNA genome. And its name? It comes from the Latin word rota for wheel, which, as you'll see, perfectly describes how it looks. It's an image that's become pretty iconic in virology.
And this image right here just captures that classic wheel-like structure perfectly. This design, this icosahedral, non-enveloped shape, it isn't just for looks. This naked geometric architecture is exactly what gives it such incredible stability out in the environment. It allows it to survive on surfaces and pass right through the stomach acid, which makes fecal-oral transmission just brutally efficient.
Now, if we look even closer, we see its unique defense system. A triple-layered capsid. It's like a tiny fortress. The outer layer, with proteins VP4 and VP7, that's what our immune system targets, and it's what defines the G and P serotypes that are so crucial for epidemiology. Then you have the middle layer, made of VP6. It's highly conserved, which makes it the perfect, reliable target for our rapid diagnostic tests. And finally, that inner core, it protects the precious genetic material and all the replication machinery.
This table kind of shows how that fortress gets built. The genome is actually broken up into 11 different segments. We won't go through every single one, but let's focus on the key players. Segments 4 and 9, they code for VP4 and VP7, which give us the P and G types we track. Segment 6 gives us VP6, that's our diagnostic bullseye. And this is a big one. Segment 10 codes for NSP4, the viral enterotoxin. That's the weapon that makes this virus so vicious.
And that right there brings us to how it makes people so sick. See, rotavirus doesn't just kill intestinal cells, which leads to malabsorption. That's only half the battle. That NSP4 enterotoxin we just mentioned, it actively triggers a signaling cascade that forces gut cells to pump out chloride ions in fluid, causing this massive, watery, secretory diarrhea. It's this devastating 1-2 punch that leads to such severe dehydration.
Which leads us perfectly into our next section, diagnosis and clinical care. Because even with the new vaccine program, the day-to-day work of identifying the virus in sick patients and guiding their care, well, that remains an absolute cornerstone of what we do.
In the lab, we've basically got two main tools. First, there's the enzyme immunoassay, the EIA. That's our rapid workhorse. It targets that stable VP6 antigen and gives us a quick result for patient management and hospital infection control. But for the absolute highest sensitivity and for the surveillance work that's now so critical, RT-PCR is the undisputed gold standard.
A positive lab result from us directly informs the clinical pathway, which, here in the Netherlands, is guided by the NVK Guideline. It's a very clear, structured approach. Step 1, clinically assess the degree of dehydration.
Step 2, for most kids, start oral rehydration therapy. And Step 3, reserve IV fluids only for the most severe cases or if ORT isn't working.
And the guideline gets remarkably precise. It's not just, hey, drink more fluids. The recommendation is super specific. 10 milliliters per kilo of body weight for every watery stool and 2 milliliters per kilo for every time the child vomits. This is the kind of evidence-based, meticulous supportive care that saves lives, and it all starts with our diagnosis.
So this brings us to our final and maybe the most critical section, vaccination and future surveillance. This is where we connect all the dots and really focus on the new imperative that the RVP has created specifically for the Dutch microbiology community.
Okay, so the new protocol uses Rotavirus. It's a live attenuated oral vaccine given in 2 doses. But look closely at those age limits. They are absolute. The first dose cannot be given after 15 weeks, and the whole series must be done by 24 weeks. These strict cutoffs are a key safety measure, designed to get the vaccine administered well before the natural peak in age for intussusception.
Now, it's so important to remember that a vaccine is not a magic bullet. It's a population-level tool, and it complements, it doesn't replace fundamental infection control. Contact isolation in hospitals, strict hygiene, all still vital. And a key message for everyone, because rotavirus is non-enveloped, good old-fashioned hand washing with soap and water is actually superior to just using alcohol-based sanitizers alone. So, this brings us to the central question for our field, doesn't it? With an effective nationwide vaccine program now hopefully crushing the burden of severe disease, what becomes the new #1 priority for us back in the microbiology lab?
Well, the answer really lies in this idea. What we used to think of as specialized research methods are now moving right to the forefront of public health practice. They're becoming essential, everyday instruments.
So here it is. This is your new mission. You can think of it as genomic forensics. Our role is evolving. We're moving beyond simply diagnosing infections to actively monitoring the entire virus population. We have to track the vaccine's impact, watch vigilantly for any signs of serotype replacement, and be the first to spot any new reassortant strains that might pop up under vaccine pressure. So let's just boil this all down. The RVP marks a historic shift from treatment to prevention. Our diagnostic work, still absolutely vital for patient care, but our primary role is now expanding to lead these sophisticated molecular surveillance efforts. Tracking G and P types isn't just academic anymore, it is essential to making sure this whole national program is a long-term success.
Just as a quick note, all the information for this explainer was compiled using a Gemini deep search. For anyone who wants to go deeper, a detailed list of all the source materials is available in the linked Notebook LM document.
So I'll leave you with a final thought to chew on. How prepared is your lab for this new surveillance imperative? What do you see as the biggest challenges, and maybe the biggest opportunities, as we all step into this new era of rotavirus control?
If you found this useful, please subscribe to our channel for more deep dives into the topics that matter in our field. And we'd really love to read your thoughts on this subject, so please leave them in the comments below. Thanks for watching.